Okay, it's 11:02. So I think we will get started. We have 77 people on, which is awesome and incredible. So welcome everyone to the inaugural Mountain Pacific Health Sciences Libraries Conference. My name is Pam Harrison. I'm one of the co-chairs. And at an in-person event, we would begin by acknowledging the Indigenous people on whose land, on whose traditional, ancestral, and unceded land we had gathered. So today we're meeting online, and let's start with a reflection on the places that we are right now. So I'm going to continue speaking, but invite you to use the chat box for your own reflection. So I am a settler with ancestors who came to Canada from Scotland and Ireland by way of Australia. I live and work on the traditional, ancestral, and unceded territories of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. Like many of you, I work at the intersection of libraries and the healthcare sector. Both systems have served as instruments of colonial and racial violence, and I recognize that that legacy continues today. I dedicate my involvement in this conference to the work of reconciliation and collaboration. If injustice is not new to our field, the past year has brought it into sharp relief. Systemic racism and violence against Black people, Indigenous people, and people of color demand our attention and action as citizens, as colleagues, and as information workers. The Canadian Health Library Association, the Medical Library Association, and many of their local chapters have stated their commitments to dismantling this oppression. So throughout this conference, you will find opportunities to do this work, both through explorations of privilege, equity, and inclusion, and by learning about ways to improve the accessibility of information and quality of care for the people we serve. So on behalf of our conference planning committee, I hope that you will also celebrate the resilience and innovation of our community during this time together. The global COVID-19 pandemic has deepened social and economic injustices that BIPOC people suffer at the hands of those more privileged. It has closed physical libraries as gathering spaces and paused the circulation of physical items. But our community has persevered, developing new opportunities for learning, making libraries safer, healthier places for our clients and our colleagues, refining the quality of our services in light of staffing changes and a growing surge of new health information that needs to be searched and synthesized, and working to improve the accessibility of information for all.
Hi, I'm Catherine Villa. I'm a co-chair for this event along with Pam. We would like to take this time to thank our sponsors for their generous support today. Our platinum sponsor, EBSCO, our gold sponsors, BMJ, McGraw-Hill, ProQuest, and Wolters Kluwer. We have our silver sponsors, JAMA, Marian Liebert, and the Network of the National Library of Medicine, Pacific Northwest Region, and Springer Nature, sorry. And our bronze sponsors, Rittenhouse and Time. This conference is a collaboration between the Pacific Northwest professional associations, namely the Pacific Northwest chapter and the Northern California, Nevada chapter of the Medical Library Association, the Northern Alberta Health Libraries Association, the Southern Alberta Health Libraries Association, and the Health Libraries Association of British Columbia. We have a few housekeeping items we'll go over before we get started with our keynote. All attendees are muted during the conference sessions, so please place any questions or comments in the chat, and they'll be addressed during the Q&A portion of each session, or at that time you may unmute yourself and ask your question that way. All sessions are recorded and will be linked on the conference website after the conference. In each session, there will be a technical support person who will identify themselves as such in the participants list. So if you have any tech issues, feel free to send them a direct message through chat and they can help you out. Closed captioning is available. Just select the closed captioning button at the bottom of your Zoom window. Our code of conduct and our incident report form are up on our website under the About tab. If you happen to have any issues, you are welcome to contribute to a joint note-taking document using Padlet, and you can find more information about this in your welcome packet. You're also invited to order a one-of-a-kind conference sticker that were designed by members of the participating associations. Congratulations to Shannon Chang from HLABC and Hilla Bloom-Steiber from NCN MLG, who submitted our winning designs, and you can find those also on the conference website. Any sales proceeds will go to HLABC and NCN MLG for scholarships. Finally, please connect with our sponsors. You can find their contact information under the vendor information page of our website. And there will also be a vendor raffle at the end of the conference. You can win one of the prizes donated by our sponsors. Check out the website for details. Every conference registrant will be automatically entered with like one digital raffle ticket, but you can get additional entries from participating sponsors by engaging with them one-on-one, attending their conference presentations. Any kind of engagement with a vendor can result in an extra entry. So be sure to connect with vendors, pay attention during their presentations for additional chances to win. So now I'll introduce our opening speaker. As an infectious disease physician and public health researcher, our opening keynote is an expert in the link between physical health and social dynamics. A faculty member of Washington University School of Medicine in St. Louis, Missouri, she is also a prolific writer. You will find her articles in peer-reviewed medical journals on infectious disease and substance use, as well as in popular magazines like Ms. in Vogue. Her research focuses on equitable access to care for vulnerable populations, including women involved with the justice system, people living with HIV, and people using substances. Most recently, she has navigated the challenges posed by the COVID-19 pandemic, both as a parent and as a physician and researcher. We are honored to have her voice setting the tone for our conference. Please join me in offering a warm welcome to Dr. D. Muthulingam.
Thank you. Thank you for the warm introduction, and I'm very honored to speak with you, and I thank you for the important reflections. I'm going to attempt to share my screen now. Let's see. There we go. Let's see if this works. Okay. And then just some contextual notes. I am in an office at our busy clinic, and my colleagues have very generously made some space, but if there's a little bit of noise, please pardon any background interruptions. And I'll be looking down at my notes, which are to the right. So again, I'm Dr. D. Muthulingam, infectious disease doctor in St. Louis, which is in the Mississippi Basin. Many overlapping indigenous nations here, but also the Cape Paw. And thank you for letting me speak to you. There have been as many plagues as wars in history. Yet always plagues and wars take people equally by surprise. This is Camus writing in The Plague. Over 1 year ago, the WHO received reports of an atypical pneumonia cluster in Wuhan, China. A novel coronavirus is identified as the cause. The WHO declares a public health emergency. In March, a rapid surge of cases in Italy overwhelmed their health system and led to unthinkable rationing of hospital and ICU care. In April, a similar, even larger surge takes place in the New York City region. Around that month, the US death toll passes 100,000. A month later, the US infection number passes 2 million. In late spring and early summer, several states in the US reverse their social distancing orders. The US passes 3 million detected cases. Moderna and AstraZeneca vaccine trials show preliminary efficacy, and the first phase 3 vaccine trials begin. In August, COVID is now the third leading cause of deaths in the US. Treatments have also started emerging. We saw remdesivir and convalescent plasma receive FDA emergency use authorization. And in September, steroids, which are off patent and affordable, are shown to be the most effective treatment to date for severe COVID. In the UK, a more contagious variant is discovered. A surge takes place in my region, in the Midwestern US, and global death from COVID surpasses 1 million. In September, the President of the United States tests positive for COVID and is hospitalized as part of a super spreader outbreak within the White House. Global cases topped 40 million. In October, the US reports that 100,000 new cases have occurred in a single day. Pfizer and Moderna have data now that their vaccines are over 95% effective. Shown here is Suzanne Brennan Fistenberg's art installation of 220,000 white flags outside of the DC Armory to represent the nation's death toll at that time from the coronavirus. Let's see if my media works. It does not. You'll have to use your imagination. But since the deadly surge in the New York region, there have been multiple deadly surges that have overwhelmed the healthcare capacity in Texas, North Dakota, Louisiana, New Mexico, and now Los Angeles, California, where it is unfortunately affecting several of my friends and family. As of Monday, there were 27 million known COVID cases in the US and 463,000 deaths. And we will not be able to advance the slides. In December, the FDA issues the emergency use authorization for 2 COVID-19 vaccines, and we began distribution to healthcare workers and long-term care facilities. That aforementioned more quickly spreading variant in the UK and a new one discovered in South Africa is now found throughout the world. In January 2021, COVID is on track to be the leading cause of death in the US. That was an extremely minimal timeline. I wanted to go through it because it can be hard to absorb how much has happened in such a short time and how much our lives have changed. I want to highlight also now that throughout this incredibly devastating plague, we have also seen unprecedented scientific collaborative efforts. Very, very soon after that cluster of pneumonia was detected, the SARS-CoV-2 virus was sequenced. Multiple highly effective vaccines were developed in less than 1 year after that sequencing. Over 75,000 scientific papers on COVID-19 were published by November, that's 3 months ago. We have reduced mortality for hospitalized patients with COVID, and that's at least partly attributed to rapidly improved medical care at the front line. Never before have so many experts in so many countries focused on a single topic so urgently. And finally, social distancing. Millions and billions of people have dramatically changed their day-to-day lives to implement social distancing. And it's worked. In April, just by implementing the person-to-person social distancing, we've reduced the spread estimated at 10 times. The ban on social gatherings and indoor venues has probably led to a 35 times decreased transmission of COVID. I don't need to tell you, but it's been incredibly difficult. There have been 2.3 million deaths in just the US. Those who don't die are still very sick, and that's what I see day to day in my work. COVID patients are sicker, need more care, and stay longer in hospitals and then in nursing homes. A subset recover and return to the hospital multiple times. Previously healthy people who are working very physically demanding jobs are now too short of breath for months on end to do their jobs or their activities of daily living. We are just starting to document the long haul symptoms, pulmonary, neurological, autoimmune syndromes that drag on indefinitely. The economic toll is not insignificant. The virus is lethal, but we have also long known that so is poverty. Lost or reduced jobs, closed businesses, impact on food security, housing insecurity, disproportionate impact on women's economic status, a recession whose impact falls much more on vulnerable populations and developing economies. There's also the component not just of human versus plague, but human versus human. Political strife has included exacerbating misinformation, polarization, and internationally, as well as here in the US, opportunistically using the pandemic to strengthen authoritarian tendencies. And just the extent of the grief and trauma. Large-scale disasters, whether traumatic, natural, or environmental, are almost always accompanied by increases in depression, PTSD, substance use disorder, other mental and behavioral disorders, domestic violence, and child abuse. I now want to hone in on one of the particularly existentially painful parts of this crisis: isolation. Happy togetherness is all alike. Every unhappy isolation is unhappy in its own way. What I mean is that we are experiencing very different realities. In my case, I'm living at home with a husband, a 1-year-old and a 3-year-old. At the beginning of the pandemic, I was able to work at home as on call. So we were in a house with 2 very small needy children without childcare or community support. But now I go to work every day at a hospital, and so my life is actually not that dissimilar from what it was before. But other friends and family are staying at home every single day for the last year. And meaningful social connection is a key to human health and survival. Even prior to the pandemic, there was recognized that there's a pre-existing public health crisis of social isolation and loneliness. This social isolation is linked to increased risk of death from all causes. That connection is very robust and higher than that of tobacco. 28% of Americans live alone, including many who are frail or elderly, and they have had little to no human contact for several months. There's also an element in which we are losing the rhythms and rituals of our life, and that can be very destabilizing. And then our children also have sort of an unpredictable impact on their development and education. And it does appear preliminary data shows that this is disproportionately affecting children from more vulnerable and economically susceptible to have less resilience because of fewer resources. In those communities, the lack of education has had a higher impact. So what do we do in the face of this grief, especially without each other? We have missed funerals, weddings, haircuts. We are asking people to forego communal dining, choir practice, their church, their festivals, their sexual partners. Our beloved restaurants and yoga studios are closing, some forever. We fight with the people we love because we have different ideas about acceptable risk. What do we do in the face of this drastic, devastating change? As wildly incredible as it is, everything that we are experiencing, I'd like to propose that we go to another timeline. A little while ago, not so long ago, to contextualize some of this experience and to look for lessons, I believe, that are there. In June 1981, the CDC received reports of a cluster of atypical pneumonia in Los Angeles, California. These pneumonias all occurred in young gay men. That same summer, a cluster of a rare cancer, Kaposi sarcoma, is also reported among gay men in multiple cities. Initially thought to be a disease only of gay men, it is then also diagnosed in hemophiliacs, Haitian immigrants, female partners of men with infection, those who injected drugs, and soon children, including mother to child. Before this current pandemic, it can be hard to remember how terrifying this was. The Irish poet John Montague in his memoir describes visiting a physician friend in New York City, who tells him, "But these are special patients, suffering from a new malady that frightens people, a disease no one wants to deal with. Even the hospital staff are scared. They think of it as a kind of plague. People do not know how to react. Nurses, even some doctors, are so wary that they refuse to bathe these patients or dress their sores. So they are very lonely as well as sick, ostracized as well as impeded. In response to this emerging crisis, in 1984, a highly controversial move, the San Francisco Department of Public Health closes the bathhouses and private sex clubs in the city because of the concern for the potentially high risk of transmission in this particular setting. Multiple other cities also follow suit. This prompted protests and a political debate about public health and civil liberties, and also what felt like an attack on the gay community itself. In 1985, Ryan White was a teen who contracted HIV from a blood transfusion. He was banned from attending his school. After a 10-month legal battle, he was allowed to return. 30 children were withdrawn from the school, 365 stay. Ryan White presents a pure face, an innocent, someone who suffers without the stigma of being a sexual or racial minority or outsider, somebody who wasn't, quote, asking for it, humanizing the illness for the larger US population. In 1987, ACT UP forms to protest the unaffordable cost of the only available medications and the extremely slow pace of the approval process. It adopts the motto, silence is death. They would be heard, they would be seen. Several days after the sit-ins, the FDA streamlines the drug approval process, which is a process we still use today. Activists began meeting with the head of the NIAID, young Tony Fauci. ACT UP fought against the erasure of a community of people. At that time, many people who died of AIDS-related causes did not receive funerals, due to both the social stigma of AIDS felt by the surviving family and the outright refusal by funeral homes and cemeteries to handle the deceased remains. Without a memorial service or gravesite, the AIDS memorial quilt came to be. This is in 1987. Survivors can remember and celebrate their loved ones' lives and visualize the unfathomable loss. This is the National Mall in Washington, D.C. And throughout this time, people died. They died and died and died. A generation of artists, intellectuals, parents, lovers, friends. So far, I've focused on an extremely American-centric story. Globally, HIV has killed 75 million people and still ranks as one of the deadliest pandemics of all time, devastating entire regions of the world. What do you do in the face of so much grief? Of not just the loss of individual lives, but devastations to entire communities, of stigma, of being decimated by the very human pursuit of sex, comfort, community, and joy. Is it possible to counter it? Adrienne Marie Brown writes, I touch my own skin and it tells me that before there was harm, there was a miracle. The answer is sometimes to take joy anyway. Here we have the Sisters of Perpetual Indulgence, an order of nuns who take vows to promulgate universal joy and expiate stigmatic guilt. The sisters believe all people have a right to express their unique joy and beauty and use humor and irreverent wit to expose the forces of bigotry, complacency, and guilt that chain the human spirit. In 1983, Michael Kellen and Richard Berkowitz were diagnosed with AIDS, and in conjunction with Dr. Joseph Sonnabend, one of the first physicians to treat HIV in New York City, they developed a pamphlet, How to Have Sex in an Epidemic. It was one of the first publications to recommend using condoms during sex, rejecting the standard abstinence-only counseling. It is one of the foundational texts of modern safe sex. You can see the table of contents here, where they give sort of this contextual understanding of what is AIDS. CMV is one of the opportunistic infections that would result in the setting of AIDS. And you can see that they spoke frankly in plain language, the language that people actually use to detail pragmatic approaches to risk management and sexual activity and living your life as a sexual human being while trying to be safe and to survive. The HIV epidemic brought us the notion of safe sex. Not just abstinence and threats, but also inventing a sex-positive approach. One of the other foundational texts from around this era, actually right before HIV was really known, the Guidelines for Recommendation of Healthful Gay Sexual Activity wrote, "More than the avoidance of STDs, it is the human condition in which the physical, mental, and emotional needs of a person are in balance. Healthful sexual behavior is an expression of one's natural sexual drives in health-free, disease-free ways." The HIV epidemic radically changed how sex was practiced. Not only sex with condoms, but turning to communities like the leather community, transactional sex communities, and BDSM communities, which had long established practices of negotiating each act of sex with great specificity. This became a useful model for communication about sexuality and risk and shaping new norms of consent. Around this time, a parallel development in the injection drug community, the idea of harm reduction, which is that abstinence-only approaches to substance use and sex are unrealistic. The idea is that imperfect efforts to public health are better than no public health efforts at all. We educate people on the different levels of risk with different activities. And rather than a binary of good and bad activities, we acknowledge that there's a gradient of risk. And we try to substitute high-risk activities with lower risk activities or find ways to modify that risk. In the setting of injection drugs, we can advise don't share needles, set up syringe exchanges to use new ones rather than old ones, don't shoot up alone. Unfortunately, as we are also having a resurgence of opioid use, these lessons remain potent and still in process in terms of implementation today. If you don't account for pleasure, that people need sex, that people do drugs because it feels good, that we need joy and connection, especially when we are grieving, you will miss the fundamentals of how humans work, and therefore the fundamentals of how to make effective public health policy. We already know that abstinence-only approach and a shaming approach doesn't work for sex. It doesn't work for drug use. It actually leads to worse outcomes. It probably won't work for social distancing either. Certainly, there was an urgency to flatten the curve early in the epidemic, and it paid off, although there were other times where we couldn't sustain that for a number of reasons. But as our pandemic lingers for a year and a half, potentially longer, as we work towards herd immunity, it prompts a question of what is sustainable, what is reasonable, what will have public buy-in and public trust. We need to recognize that risk is not binary, even if our political polarization can make it seem so. We need to recognize that shame and stigma are not useful public health strategies. Coming back to this timeline, let's talk about harm reduction for the COVID age. Most people need social interactions, so we give individuals tools to understand and navigate that risk. We aim to minimize, if not eliminate, risk and make sense of what will allow us to keep going. We can advise, for example, that outdoors is much safer than indoors, that going on a jog together is better than going to an indoor restaurant. If you hang out, mask up, don't share food, wash your hands, get tested frequently. But also we need to recognize that you can't address institutional failures with individual blame. We need policies that support financially individuals to incentivize staying home so that they're not choosing between financial survival and infectious disease survival. We need adequate testing infrastructure. There are examples of setting up outdoor public spaces that facilitate outdoor hanging out, and we need to educate the public. And stigma and shame often backfire. There are important differences between these two pandemics, so I don't want to oversimplify that, and not everything is translatable. HIV is sexually transmitted. It's also vertically transmitted from mother to child during childbirth, and it's bloodborne, whereas COVID-19 is droplet and airborne. HIV is deadly over months to years. COVID is deadly over days to weeks. HIV did have stigma affecting marginalized communities like the LGBTQ community, IV drug user community, and people of color who were affected disproportionately. COVID-19 ostensibly affects everyone, but it has disproportionately affected people of color, the working class, and poor. There is a component in which both pandemics were intertwined, HIV and the sort of what was called the culture wars and the politics of that time. But in COVID-19, it has a different mechanism. It's intertwined with partisanship and misinformation in a very simplified way. I think the big thing is with HIV, the behavior affects yourself and all your sexual or needle sharing partners and then their partners. Whereas in COVID-19, behavior affects everyone in your airspace, which can be quite extensive, and then their airspace network. And I don't know, you know, HIV in 30 years infected 76 million people that we know of and killed 32 million. In 1 year, COVID has infected 106 million that we know of, and there are 2.3 million who are dead. But I want to emphasize the similarities to illuminate sort of our path going forward. In HIV, we're navigating new ethics, etiquette, and norms around sex and drug use and everything related to that. In COVID-19, we have to navigate new ethics, etiquette, and norm around all in-person interactions. We're learning to risk stratify, however, in both situations. We can change our practices in both situations. In HIV, there is an idea of Sarah sorting. This may be less relevant now because there is this idea that if you have these highly potent treatments in HIV and are undetectable, then you are untransmittable. Before we sort of had that confidence, sometimes people would only have sex with people who they knew were HIV negative. They themselves were HIV negative, or HIV positive folks would partner with people who were HIV positive. And I think similarly in COVID-19, people are trying to pod, which is to find other people, a closed circle of similar risk approach. It's important to keep in mind that both Sarah sorting and podding is only as good as your trust in the individuals involved. And then in both settings, there's a limitation of absence-only approach. And there's a need for information and empowerment. During the 80s and 90s, there were different limitations on access to information and the stigma. In our current era, it seems like there's access, but then we have this issue of misinformation. This is very simplified. I'm not doing justice, but there are things that came out of these very difficult times. In HIV, we had talked about these new safe sex and consent practices. We came up with the radical idea of harm reduction. The science of HIV revolutionized immunology and virology, which has affected cancer treatment, autoimmune disorders, a number of fields. It was a big part of the hospice movement and contributed to developing that. So this is Dr. Sonnabend, who had helped write the How to Have a Sex in an Epidemic, also developed the methodology of community-based participatory research. We rebuilt the public health infrastructure. And we developed things like the Ryan White program, PEPFAR, and a global health approach. And I think that really reflects a strong federal leadership program that countered HIV with resources and political will, even if initially there was a lot of reluctance. PEPFAR was done under George Bush, W. Bush, under a conservative president, but was instrumental in really turning the tide on global HIV. With COVID-19, we're still figuring out what's going to grow from this. We do have, and there was always the influence of gay liberation and AIDS activism that was critical in moving forward a lot of these landmark changes. In COVID-19, we have ideas of mutual aid and collective aid. We are rethinking the social contract, which I'll come back to. We, in the interim between the HIV pandemic peak and the COVID-19, we defunded public health. So it was severely it was very understaffed, as we can see, and now we need to rebuild that public health infrastructure. There is a surge of interest in infectious disease and public health from a new generation, and it has become intertwined with the fight for anti-racism. The year of COVID is also the year of the George Floyd protests, of recognizing the forces that lead to health disparities in Black and Brown communities who suffer disproportionately from COVID and HIV and strokes and diabetes and asthma. These are the same forces that give rise to over-policing and its brutality. Structural racism obviously didn't start with COVID or these protests, but the great anguish also brought to bear a reckoning, one in which we cannot look away. This is also about grief and about fighting, but it's also about the potential for change, even if the road is long. Amartya Sen is a Nobel-winning economist, and he has written that famines are not natural disasters. Crop failures, bad weather, these are natural disasters. Famine, the failure to sustain a people when there is great abundance, is an economic and political failure. The same is true for a virus. A plague is a natural disaster, but the crisis in its wake are political and economic disasters, and the opportunity to rebuild those things. All the crises we are having now, childcare, violent systemic racism, public health infrastructure, women's economic equity, access to healthcare, worker protections, and poverty, these were already issues that we had. The coronavirus pandemic cracked them open, illuminated and accelerated what was already there. What we now have is the opportunity to build it again and get it, if not right, better, and examine what it is we owe each other. At the root of both of these histories is the need to share resources. Librarians play a key role in developing the resources, such as Jerry Perry's AIDS Sourcebook in the late 80s and early 90s, as well as navigating them, creating and sharing information, navigating data that it becomes knowledge, and empowering people in a time of fear. Paulo Freire, the educator has a duty of not being neutral in the age of misinformation. This week, the daily case count for the US was under 100,000 for the first time in months. As of yesterday, 9.8% of the population have received at least one dose of the vaccine. There is profound grief, trauma, and hardship. There is great scientific achievement. There is the anguish and opportunity of facing the structural inequity and racism that is deeply embedded in our society. And finally, refer to Mark Doty, who was a tremendous poet during the HIV/AIDS era. He wrote, "What did you think? That joy was some slight thing?" I hope that we can also think of the joy as an essential component of how we approach and survive a plague. Thank you for your time. I'm happy to answer any questions.
Thank you so much, Dr. D. Everyone, if you would like to put any questions that you have in the chat, I will be reading them off, and looking forward to your questions. That was a great talk. We have about 15 minutes for questions. Okay, so we have our first question here, which is, do you see a role for graphics and comics in communicating COVID as it did in HIV?
Yeah, that's a great question. I should have spent some time, but the public health campaigns for knowledge, for information, sorry, I'm having a lot of word finding problems, during HIV, both in the 80s, 90s, 2000 are just incredible. I would like to see that. I think there's a role in COVID for creative public health messaging that I think we're still kind of wrapping our mind around. But I think it's really incredible, some of the posters in multiple communities throughout the world about how these messages about safe sex and safe practices with needles were approached with humor and joy, and sort of have been sort of, I hope they're somewhere in a museum. There's a really incredible history in the last 30, 40 years. And so I think there is a role for artists and writers to step up in COVID-19 and present that messaging on how we can navigate it.
Okay, next question. Christine says, thank you. The next question is from Kitty Canetti. She said, excellent talk. What do you think is the most important first step for change in the COVID-19 environment? While you think about that,
yeah.
Carolyn Martin just posted some publications on COVID in the chat as well.
Oh, great. Yeah, so let me come back to the change in the COVID-19 environment. So I'm often advocating for sort of the grassroots up, listen to patients, listen to communities. There is the way COVID-19 evolved in the last year, and I think this is true for the early years of the HIV epidemic as it was evolving in the US, was actually a top-down issue. There was sort of a vacuum. And there is a way in which you need to use the federal government and the powers that be to coordinate a response. And I think one of the important steps I think has already happened, which is a change of leadership in January, and sort of a signaling to the larger society that we are going to listen to reliable science and information. We're going to put forth resources, not just for the development and dissemination of vaccines and medications, but also for the social risks that people are taking, their economic well-being, their access to healthcare, their access to childcare. And so I think one of the big things is that you do need leadership that's going to coordinate all of the elements, and strong leadership that's willing to put in some money and time. Oh, great. Okay. Graphicmedicine.org has some publications on COVID.
Yes. The next question here is from Chris Schaefer. He just says, as someone who works at UCSF, really appreciated the parallels you drew between the HIV/AIDS epidemic and COVID. The community reaction to AIDS via groups like the Sisters and ACT UP advocated for greater access to care. The political response to COVID has in some sense been advocating for less. Can you talk about your thoughts about the difference in the responses and how libraries and information professionals can react to those differences?
Maybe can I ask you to clarify by what you mean by advocating for less, like less resources, less interactions?
So, I mean, realistically, a lot of people have been advocating for less public health response, you know, don't wear your mask, don't get vaccinated. You know, it's almost the opposite of asking for more help.
Yeah, I think that's been such an interesting phenomenon this year. And I think, you know, I wasn't sure whether to draw a more direct parallel to sort of the response to closing the bathhouses, which was, you know, on one hand, it was an attack on, you know, sex and partying, but these are also sites of community and where people gathered. And I think there is always, and this is, I think the big thing about the history of public health is that there has always been resistance to public health. Typhoid Mary kept breaking out of her because sometimes public health does overstep. They like kept her in a prison. And you really do have a tension between civil liberties and public health policy, which is absolutely about controlling bodies for some greater good. So this whole anti-masking, anti-vaccine, I think there's a lot of messy variables in that, which is, you know, some politicization that is, well, it's all political, but like, I felt like there were individuals and factions that benefited from that kind of rift. And it can be very frustrating, certainly as, you know, if you're people looking at the public health and you're taking care of these patients. But I think there's something about information that seems to be very different from the HIV. At that time, and you know, I wasn't there, but it seemed like there was not information. It was hard to find. And now it's like good information and bad information is not distinguishable. And I think the librarians and informational professionals, what I imagine is, how do you interpret that? How do you know what is reliable? It's sort of this epistemic question. And I think that as teachers and interpreters and guides in that sort of morass, like never, it's just such an explosion of information. And you have either unintentional and intentionally misleading threads of things happening. So I'm hoping to turn to you guys as sort of leaders of how do you navigate knowledge and how do you put together data and synthesize it in a way that's meaningful for people, in a way like the pamphlet about safe sex was just like, this is what it means to do these sexual practices safely. And I think that's a role that I think, you know, healthcare workers and librarians and informational professionals, and I think that's where a lot of the work needs to be done. Does that make sense?
Thank you. We've got a couple more questions here now. Morgan says, it was amazing to be reminded that truths we take for granted today were revolutionary less than 40 years ago. Do you think there will be any truths about the public health that come out of this pandemic?
Obviously this is like predicting the future, but you know, I really hope that people understand how, and I don't think this is revolutionary because other countries do that, understand how deeply embedded public health is in economic well-being. That you can't have public health without housing or education or economic justice or racial justice. And you know, you can kind of like lose the boundaries a little bit, but you really can't have public health without addressing basic civil and economic rights. And I do think there's a recognition of that and people fighting for that, that we need to shore up our social contract of what we provide people, that we provide healthcare, that we provide some kind of housing security, food security, and education for children. I really think that that's my sense of sort of really recognizing that public health isn't just people who are tracking or down cases. It's really this deep component of how we run society.
We have another question here from Judy Kramer. She says, how about using public librarians to distribute authoritative COVID-19 information? They're integrated within their communities and regularly provide programming to meet their community's needs. They could be a great source of the truth about COVID-19 and vaccinations as a partner of the CDC and local health departments.
Yeah, absolutely. And I think this is where, you know, earlier I was endorsing the strong top-down like federal leadership on this, but if you really want engagement, you have to start with the local communities. My friend works on sort of vaccine engagement in Black communities in St. Louis, and people don't trust random people to walk into their community and tell them what to do. And I think if you build those partnerships in the community, and the library is absolutely a nexus where it's in the community and there, and should be funded to support these kinds of efforts as a place to go where you know the individuals, you know your leaders go there, you know your church goes there. And I think absolutely these need to be the infrastructure and relationships we have to be building, because that's where the trust starts. I absolutely agree. I think that could be a really great opportunity.
Thank you so much. I'm not seeing any other questions in the chat. Does anyone else have anything they would like to put in there? I'm going to give you guys a few seconds.